The next is the topic is unpredictable outcomes post-phakic intraocular lens implantation. The chief presenting author is Garvita, DABAS. You're there. Thank you for coming.
A very good morning, everyone. Welcome to my presentation of unpredictable outcomes post-phakic intraocular lens implantation. This is a case series of 4 cases where we had completely uneventful surgery and yet we were met with surprising outcomes. So phakic IOLs have shown promising visual outcomes, but they have their own set of complications and challenges that we're all aware of. And sometimes, despite meticulous preoperative planning and calculations, one may encounter unforeseeable consequences. My first case is regarding a 21-year-old female who complained of a suboptimal visual gain in the left eye post an uneventful surgery. So as we can see, her pre-op parameters were, she was 6'6", BCVA refraction was high myopic, lens implanted was 8.5 diopter and -9 diopter. Post-operatively, there was the vision gain in the left eye was low, which was 6-9 parts. And after we did the AIOS2025, we were surprised to discover the orientation of the lens was wrong in the left eye. So yes, due to the reverse orientation, we explanted the lens and reimplanted the new ICL in the correct orientation. The post-op vault was good, 575 microns, and follow-up is almost 2 years where the patient is been stable. She is still under observation just to avoid any early cataract formation, but yes, she's doing well as per today. My second case is regarding a 27-year-old female who again complained of less diminution of vision in the left eye after 2 months of uneventful surgery. High myopic, size implanted in both eyes was a toric ICL 12.6. Left eye, diminution of vision after 2 months was 6-9 parts. So we redialed the lens, we found it was misplaced, and after redialing, again the patient presented with diminution of vision, so she had to undergo again redialing after 3 weeks after the first dialing, followed by a second redialing almost 4 weeks later. So ultimately, we decided to explant the toric ICL and implant a bigger size ICL because there were already 2 failed redialing attempts. Post-op 6 months, the patient is stable with a vault of 435 microns. My third case is regarding a 23-year-old female who underwent again uneventful phakic IOL implantation with a good gain of vision. However, at 3 months post-op, she still complained of a high vault. She was high myopic with -13 with -2 refraction in the right eye and -15.5 with -2 in the left eye. Her parameters pre-op are all noted here. And as we can see in the AIOS2025 pictures, on day 1, the vault was 1120 micron. At 1 month, 1250 micron. And at 3 months, it was almost 1200 microns. So we were, yes, surprised why such a high vault. Is this acceptable? What to plan? So the left eye was kept under observation and the right eye was planned almost 3 months later after observing the behavior of the lens in the left eye. The right eye was planned with a smaller ICL, which was 12.1, as even against the manufacturer recommendation. And as we can see, the right eye vault was 691 microns, whereas the left eye thankfully maintained at 1200 microns. The patient is still under observation. Last case, the patient again underwent an uneventful phakic IOL implantation, both eye with a good gain of vision 6.6. High myopic patient, white to white was almost equal, 11.13 and 11.14 in the left eye. Remaining parameters were normal. However, post-operatively, we found the left eye had an extremely low vault of only 52 microns. So, to plan the left eye surgery, ICL exchange was planned with a bigger ICL. And post-op 1 year, the patient is found to be stable. This is post-ICL. This vault is still 136, better than 52 microns, even though we've gone with a bigger ICL. But we still keep under observation. There are more studies available in the literature where less than 250 microns patients have been doing well, and we intend to keep her under observation. So the patient is 2 years follow-up right now, stable vault maintained, and the patient is still doing well with 6.6 vision. I would like to finally discuss all my 4 cases. In the first case, there was a left eye reverse orientation of phakic IOL, and AIOS2025 proved to be a useful modality to correct our orientation. the second case where there was a left eye rotational instability where the lens was explanted and a bigger lens was implanted so that the toric ICL remained in place. The third patient had a significantly high vault for which the patient was kept under observation because the angles were open, there was no pupil diameter change, and such patients may be kept under observation. And in the last case, due to low vault, again, there is a risk of cataract surgery, cataract formation. However, low vault patients less than 250 have been reported to stay good, doing well under observation. So we intend to keep her under observation as of right now. Thank you.
Thank you so much,
These
Garvita.
are my references. Thank you.
You have not shown here your affiliation.
Yes, sir.
Your affiliation.
Center for Sight, sir.
Not written in there.
It was on the main. Sorry.
That means you're unknown. Just hold on. I think it is very important to learn that whenever you're putting your first slide, your name, your affiliation, your degrees has to be mentioned, That's a very important part for any presentation when you're presenting paper.
Right.
Okay. Did you learn something from these 4 cases?
Yes, sir.
So what did you learn for the first case, where you implanted inverse?
So my personal takeaway is that the surgery of ICL may seem, the intraoperative part
No,
may
what
seem
did you
easy,
learn
but
because the lens were inverse? So what did you learn for that?
so post-op thorough observation and
Not
check.
post-op, it has to be intra-op, no?
Intraop, we have to be careful, sir.
Be careful. How do you avoid inverse implantation in ICL?
So proper loading, first of all.
How do you load it? What are the points to be seen so that you don't load it in a inverse manner?
So as if we talk about the ICL, there are markings that give us the leading haptic and the lagging haptic. So we have to make sure it's loaded well.
Where
and
should
even
the marking should be?
Sorry, sir?
Where should be the marking placed? Which side? You
the
have
leading.
4, 4
yes, there was
haptics.
4. Yes.
So where exactly the marking and where should that marking be facing?
So upwards and forward.
You should learn further,
Yes.
AIOS2025 is too late. What would be better to judge these things?
First, the slit lamp
So
examination,
if you
sir.
have an intraop OCT, which many people have acquired now,
Okay.
I think, Center for Sight Dwarika now
Yes,
has
we
the
have it.
IOCT microscope with the silk procedure.
Yes.
That gives you, on the table you can assess and you can manage these cases. That is one. And many things to be learned. I think I have one question for there. Just one question, please.
Just referring to your second and the fourth case. First was the rotational instability and the fourth case was 52 volt. I mean, would you not have taken 2 sizes higher up especially the last case, because even after the second surgery it was 136.
Yes.
So were you mismatched in even the second calculation?
Sir, the other eye was doing well. So we had stepped up 1 size because we were afraid if we step up 2 sizes, we could land up with closed angles or any other complication.
You should have gone a 2 steps, 2 sizes above.
Because the manufacturer normally would not allow you that. That's the major concern. The only thing which you have to learn is, your measurement has to be accurate. The white to white measurement has to be done appropriately. If you see the second case, the white to white was a 10.9 or something. It was smaller white to white. So
Yes.
you always have a difficulty there. So if you have white to white more than 11.5, you're going to have a difficulty there. So you have to have some concern, some your nomograms for these cases which are of the slightly away from your normal range. That is the learning.
Right.
But your name is, not like a Center for Sight, Garvita DABAS. DABAS?
Yes.
DABAS. Thank you for presentation.
Thank you, sir.
Tip from you, sir.
Yeah.
What is the best way to measure white to white?
Look, it depends on your institution. If I have the facilities, yes, we'll use so many things. The best is still the manual digital caliper done in a proper position. Patients should be lying supine and it should be measured under microscope so that you have an accurate adjustment. And second, maybe any other device which is automated. It can be your IOL master, it can be your pentacam, it can be anterior, anything. And these 2 measurements should be matching. Because one, if you suppose I go for a IOL master 700, I know that it is going to be larger than the manual keratometer. If always there's a difference of 0.5 or so. If that is happening, I'm sure that is correct one. And whichever you use should be your own hand. so that your reliability is there in the subsequent cases also. But people talk about, doing UVM to sulcus to sulcus. People talk about angle to angle by, high definition OCT pictures. All these things can be good assessment. Ultimately, the day will come where all these parameters are taken: AC depth, white to white, angle white to white, sulcus white to white, and the other parameters, the lens rise. These are all parameters should be included, and you'll have AI-based formulas to look into that. So that's the feature subsequently.